I'm going to tell you about this program that we developed and are still developing and are still in the midst of a randomized trial about it called Alive PD for prediabetes or prevent diabetes. Right. So you all know this, it's a huge problem, 79 million Americans, we have to do something about it. We know that lifestyle changes work if you can get people to make the changes. And that's been proven with the diabetes prevention program, which reduced the risk of diabetes with diet and exercise. I'm going to fly in the face of academic presentations and give you the bottom line first. We found a statistically significant treatment effect at 3 months with hemoglobin A1C, fasting glucose, and weight loss. And this is the only fully automated program for pre-diabetics, and it's the only online program with evidence from a randomized trial. I'll tell you more about that as we progress. This is being done in collaboration with the Palo Alto Medical Foundation. They've been wonderful collaborators. We had a recruitment target of a recruitment target of about 320, and they made it 340, so it's been great. We identify eligibles through their electronic health records and confirm eligibility. The subjects come in, get their blood tested and their weight taken and so on. This, let's see, this is the pointer. This was a critical decision. They're eligible if they're pre-diabetic by either fasting glucose or A1C. That was wonderful in that it enabled us to recruit 340 people in a very short time. But you'll see the consequences of that is that many of them are not pre-diabetic by A1C. So we have 340 people, recruitment is complete, and they are randomized to either begin the program right away or after a 6-month delay. So this is some of the characteristics of the sample. This is really amazing because in almost every health-related study that you see, it's like 80%, 85% women, and we've gotten 69% male. And I think that may be interesting. Maybe there's something about this format that men feel more comfortable with or something like that. At any rate, this was surprising and I think very exciting. As you can see, they're overweight and obese, and a good mixture, and most of these other are actually Asian, which I haven't analyzed the data yet on that, but that's going to be a challenge in terms of, rice, for example, as a fairly major dietary component. They're middle-aged, 55, mean of 55. And here you can see, so 109.9, the fasting glucose limits are 100 to 125 currently. So these are at the low end in terms of fasting glucose, but this mean is actually below what is defined as prediabetes by H1C. And when I wrote my annual report to the federal government about this study, I actually said, well, gee, our hemoglobin A1C is so low we may not be able to see significant results. That was before I had the results. So this is what happened. It would be nice if this slide were flipped the other way, but 55% of our sample are actually in the normal range according to A1C, and only 45% of our sample are actually pre-diabetic according to A1C. And the lower you are, the harder it is to see further lowering in any subject. So this is our design. So we have clinic visits, baseline 3 months, 6 months, and 12 months. and that both intervention and control attend baseline at 3 months. And so the data I'm going to show you are for 272 people who have reached their 3-month clinic visit. So this is early days still. We still have another we haven't gotten up to our 240 yet. So here's the actual changes. So weight change, this is 3-month weight changes, change in control, change in intervention, highly statistically significant. Fasting glucose, or A1C, change in control, change in intervention, highly statistically significant. And the same with fasting glucose, highly statistically significant. I've read in papers that you don't need a control group because the control group doesn't lose significantly. Well, that's not right, because all of these are actually, in the control group, these are actually significant individual changes. So how big are these changes? They're modest. These are modest changes, but I want to tell you that these are, this is a fully automated program. So there's no counseling, no human involvement here, no personal counseling or anything like that. So this came out, the U.S. Preventive Services Task Force, this just came out about a week ago. Behavioral counseling to promote a healthful diet and physical activity for cardiovascular disease prevention. Their interventions that they reviewed were intensive. Interventions involved an average of 5 to 16 person contacts over 9 to 12 months. Their intensive combined lifestyle interventions produced a fasting glucose average decline of 1.86 milligrams per deciliter, and we got 3.5 in this early analysis. So something good is happening. So this is a fully automated algorithm-driven program. It's a 1-year program. It can obviously be shortened, but it can go for up to 1 year. And I want to say here that this is a program that I'll show you more about it, but it's email and web driven. There is a smartphone app attached to it, but this is not a smartphone app. This is a full 1-year program. Concurrent emphasis on both diet and activity. And it was based on this earlier program that we developed called Alive, where we proved in a randomized trial that it did in fact change people's physical activity, increase their physical activity, decrease their saturated fat, and decrease their sugar, and increase their fruits and vegetables. So there's an email push. That, what I mean by that is once a week we send them an email with suggested small step tailored goals, and I'll show you a little bit about that. But small step goal setting is sort of the heart of the program. There's an individualized web page, automated IVR phone coaching. So the phone system was actually developed in collaboration with Abby King at Stanford. And so it is integrated with the system in the sense that the phone IVR system knows where they are in the system. It knows whether they've chosen a goal recently. It knows a number of things about them that it can interact with them about. And there is a smartphone app, but the smartphone app is designed to help them to choose goals or report on their goals or schedule their physical activity. It's not designed to deliver the whole program. Behavioral strategies, as I said, individual small step goal setting, frequent reminders. In our previous study about the Alive program, that was the one thing people liked most about it, was the reminders that kept their mind into the fact that they wanted to do better about a number of things. Tailoring to individual eating and activity habits. We have a baseline questionnaire. I'll show you a bit about it. And we give them goals based on their stated current activity, content based on behavioral research, overcoming barriers, et cetera, promotion of social support, principles from mindfulness and positive psychology. My husband is a behavioral psychologist, and he's part of the program. And there's logging and quizzes and competition and so on. So we did a lot of work in the development of this program to promote engagement, because you can have the most wonderful program in the world, but if people don't continue with it, you might as well not bother. So one thing we do for engagement is to engage different learning or participating styles. So we have infographics, we have quizzes, we have phone-based coaching, in addition to the text content. We have a point system with challenges and monetary rewards. We have a team system where the teams compete for making progress, and they also support each other, and a messaging system where the teams can communicate within the teams or across teams. And so our participation has been good. This is our first 3 months, and participated one or more times during the month. We still have 78 people participating in the 3rd month of the program, and the average number of goals chosen is about two goals a week. 2 goals a week. And that participating means they either chose a goal or reported on a goal or accomplished a goal, answered a homepage quiz, logged with the tracking tool, or sent a message. So this is not just opening the page. This is some actual participation. So now I'm just going to go through and show you some of the screenshots of the program briefly. There's a baseline questionnaire. It's fairly detailed, and we give the goals based on their answers to this. So we could suggest goals to them that might say, eat a smaller bowl of oatmeal, or eat oatmeal less often, or something like that. At the end of the questionnaire, they get feedback immediately. This is in the setup part of the program. And it's detailed feedback. So this is this person's top problem carbs: potato chips, cereals, regular beer. So this is some specifics that the person can know right at the beginning that they might need to work on. There's an activity plan system. The program assesses how much physical activity they're doing now, creates a plan for them based on their BMI and their age, but they can adjust any of these things. How often they want to do this, what their long-term target is. We try to get them to 150 minutes. These people actually started out very active, so most people are not going for 480 minutes, but they can change how long it takes to get there and all of these, and this adjusts automatically and gives them a target, and the physical activity targets are based on these week-by-week steps. This is the home page. There's more on it than you can see, obviously, but so this is sort of the whole thing, and this is a little larger. They can choose their goal for the week. This is in the email. This is not the home page. So the weekly email comes. It contains an infographic. It tells them what the health note topics are for the week. They can choose their goal. They can respond on a goal, and they can write their own goal for the week. And then there's a lot more at the top of the home page that this cut off. Well, you can see this. So this is the actual home page. And again, you can't see all this, but there's an infographic. There are quizzes. Here they're choosing and reporting on a goal. Here's where they would go to the health note. We would like them to read both of those health notes every week. Let's see. They can write a note to themselves. There's a place where they can log their weight. They can send messages up here. This tracks their points. So this is a detail about goals, for example. We have some psychological, positive psychology goals. This is act as if you're confident and optimistic, and you'll start to feel that way. I will buy string cheese or other low-fat cheese to have as a snack this week. So they choose one or more of these, and they choose their physical activity goal, or they can write their own goal. They report on whether they did it last week. There are tips for each of the goals. So this is the goal they chose, and these are some tips for those goals. It keeps track, and they can go back 1 minute. Okay, let's see. That was just an example of a health note, the first health note. There was 72 different health notes in the system in the health note library. Health note quizzes, a daily tracker, the iPhone app I've told you a bit about. And so it's based on proven, widely accepted behavior change principles. We're keeping them in the program pretty well. This is a randomized trial of effectiveness. It's fully automated, so highly scalable. And I would like to test it in people who are a little more pre-diabetic than these people were, or even in an actual diabetic sample. Collaborators are Palo Alto Medical Foundation, Rob Robinelli and Krista Nazar have been running the program from PAMP's end of it, and Latha was our initial collaborator there, and these are the people at Nutrition Quest, and we have funding from NIH. And I think that's it. Thank you.